Okay, let's jump right into this explainer. Today, we're decoding the true clinical, biological, and psychosocial landscape of bipolar disorder. We're going to look way past those surface-level symptoms and uncover what's actually happening on a systemic level, relying entirely on the latest clinical guidelines and neurobiological data.
Here's our roadmap for today's journey. We'll start with the global burden, zoom into the bipolar brain, navigate the diagnostic maze, look at the pharmacological arsenal, examine lithium as a double-edged sword, and finally, look beyond medication to family therapy.
Section 1. The Global Bipolar Burden. Understanding the massive scale and economic impact. We really have to ground ourselves in the sheer scale of this disorder first.
In the United States alone, the annual financial burden of bipolar disorder exceeds a staggering $195 billion. That's with a B. This massive economic footprint is primarily driven by frequent emergency department visits, psychiatric hospitalizations, and persistent functional impairment that often leads to prolonged periods of unemployment. It's a condition that places an immense weight not just on the individual, but on the entire healthcare system. And this spectrum affects over 40 million individuals worldwide. Now, you might be surprised to see that subthreshold bipolar disorder actually represents the most common clinical presentation, at a 1.4% lifetime prevalence. These are folks experiencing mild or brief mood elevations that don't quite meet the full criteria, yet they have the highest rates of outpatient healthcare utilization. It really goes to show that classic bipolar 1 is just the tip of the iceberg. Moving on to Section 2, inside the bipolar brain, the microscopic storm. Let's zoom right into the cellular level. So you can think of the GSK3 beta enzyme as the primary villain in the pathogenesis of bipolar disorder. When this enzyme is chronically overactive, it sets off a pretty devastating biological storm right in the prefrontal cortex. We see a highly pro-inflammatory state, serious oxidative stress, and a massive drop in BDNF, which, if you're not familiar, is essentially fertilizer for the brain. Ultimately, this all leads to accelerated neuronal apoptosis, or cell death. So we're talking about very real, physical structural deterioration here. But here's the good news. Targeting these specific molecular pathways with medication directly restores order and protects the brain's volume. For example, when we inhibit that villainous GSK3 beta, beta-catenin accumulates, which suppresses neuroinflammation and actually stabilizes mood. Upregulating BDNF protects neurons from excitotoxicity, basically preventing brain cells from being excited to death, which preserves cognitive function over time. And by depleting inositol, we can literally dampen the overactive neural circuits firing during a manic phase. We're essentially fighting a biological fire with molecular water. Section 3. Navigating the diagnostic maze. Translating cellular chaos into clinical reality. Let's see how all of this manifests in the clinic. Differentiating between a full manic episode and a hypomanic episode is one of the trickiest diagnostic challenges out there. Duration and severity are the main dividers. 7 days versus 4 days. But the absolute line in the sand? That's psychosis. The presence of even just one psychotic feature immediately reclassifies a hypomanic state as a full manic episode, which completely changes the diagnostic trajectory from bipolar 2 all the way to bipolar 1. Because bipolar depression typically hits much earlier in life than major depressive disorder, clinicians have to utilize highly specific screening questions. They'll ask things like, did your thoughts seem to jump from one thing to another or race through your head so fast you couldn't keep track of them? Missing this question can lead to a misdiagnosis of unipolar major depressive disorder, which, as we're going to see in a minute, can lead to some truly disastrous pharmacological choices. To further sharpen these diagnoses, the transition to the DSM-5 really narrowed the entry threshold. It's not just about having an elevated or irritable mood anymore. Nope, Criterion A now strictly requires a persistent increase in goal-directed energy or activity. This was a crucial update because it greatly prevents confusion with simple agitation or other reactive conditions. It absolutely has to be goal-directed energy.
That brings us to Section 4. The pharmacological arsenal, evidence-based treatment hierarchies. With a clear diagnosis, we turn to the CANMAT and ISBD guidelines.
What you're seeing here are the heavy hitters. These agents represent the first-line therapies supported by level 1 or 2 evidence for acute mania. You'll probably recognize established mood stabilizers like lithium and dalvalprox sitting right alongside a suite of atypical antipsychotics. This sharply contrasts with alternative or natural treatments. Things like omega-3 fatty acids or gabapentin, they are strictly not recommended for acute mania due to a total lack of clinical evidence. We absolutely have to rely on what works chemically. Now, treating acute bipolar depression requires a very, very delicate balance. Look at step 1, avoiding antidepressant monotherapy. Why is that absolutely crucial? Because giving someone a standard antidepressant alone carries a huge risk of triggering a manic switch. You are literally pouring gasoline on the underlying biological embers. So we start with first-line agents that alleviate depression without causing a switch. And if traditional antidepressants are absolutely necessary, they must be guarded by a mood stabilizer. No exceptions.
Section 5. Lithium, the double-edged sword. Efficacy, toxicity, and strict monitoring. Let's dive deeper into this cornerstone therapy.
Lithium acts as a brilliant biological brake by directly inhibiting that GSK3 beta enzyme we talked about. But because the margin between it actually helping and it becoming incredibly toxic is so narrow, patients must strictly adhere to this comprehensive monitoring protocol. We're talking kidneys, thyroid, heart. And here's the kicker. Serum lithium concentrations must be drawn exactly 12 hours post-dose to allow for proper tissue distribution. If you miss that specific window, your blood work data is basically useless.
What's wild about lithium toxicity is how its presentation completely shifts from the gut to the brain, depending on whether it was a rapid overdose or a slow accumulation. An acute overdose hits the stomach hard and fast with severe gastrointestinal issues, but chronic toxicity, that can happen just from getting dehydrated while on a stable daily dose. It completely bypasses the gut and goes straight for the central nervous system, causing coarse tremors, slurred speech, and really severe neurological deficits.
And I mean, even simple, everyday choices matter here. Because your kidneys process lithium a lot like sodium. Popping a common painkiller like ibuprofen reduces renal blood flow. This traps lithium in your body and dangerously spikes your blood levels. On the flip side, increasing your morning caffeine intake promotes renal excretion. It flushes the lithium right out and completely destroys its therapeutic efficacy. It is a biochemical tightrope walk every single day.
Finally, Section 6, Beyond Medication, Family Therapy, Healing the Psychosocial Environment. Let's pan all the way out to the systemic level.
We cannot treat the cell and ignore the living room. This quote captures a profound clinical reality. While genetics set the stage, psychosocial and family stressors pull the strings on the course of the disorder. A disruptive family environment, specifically one with high expressed emotion, which means a lot of criticism, hostility, or emotional over-involvement, can directly trigger sleep disturbances and severe manic relapses. The external environment literally dictates the course of the internal biology.
To combat this, clinicians use family-focused therapy, or FFT. It's a highly structured, evidence-based intervention designed to train both the patient and their primary caregivers in essential emotional regulation skills. Over 15 sessions, the whole family moves from simply understanding the illness to actively learning how to communicate without hostility and solve problems cooperatively. They don't just watch the treatment happen, they actually become a core part of the treatment team.
And the data backs this up beautifully. In a randomized controlled trial, adding FFT to a patient's medication plan significantly reduced family hostility and profoundly improved the patient's overall quality of life across both mental and social domains. Meanwhile, the group receiving only medications saw no significant decrease in that toxic expressed emotion. Pills can absolutely stabilize the brain, but they definitely cannot teach a family how to communicate.
As we wrap up this explainer, I want to leave you with a provocative question. We've talked about the $195 billion burden. We've explored the intricacies of the GSK3 beta enzyme, the incredibly delicate dance of lithium monitoring, and the undeniable data proving that family therapy prevents relapse. But if this condition truly requires treating both the microscopic cell and the macro family dynamic, is our modern medical approach really equipped to support the kind of holistic healing this condition requires? Something to think about. Thanks for joining me on this explainer today. I'll catch you next time.